Bismillah ar-Rahman ar-Rahim. My name is Dr. Khalil ا.د.خليل. I'm going to speak about orbital diseases and related problems. I'm an associate professor at Mutah University, Department of Ophthalmology and Visual Sciences. So the orbit is a fairly large house of the eye. It's around 30 cc's, and it has 4 walls, as we will be seeing now. The apex is directed towards the cranium, and the base is directed towards the face. If you look closely here, you will find that 2/3 of the eye is found inside the orbit, and 1/3 is outside the orbit. This doesn't really apply to African Americans. Usually African Americans, they have shallow orbits, and more than, let's say, half of the eye can be outside the orbit. Now, the orbit is bounded by nice balconies. This is how I imagine them. These are the sinuses of the orbit. We have the frontal sinus, we have the maxillary, we have the ethmoid, and the ethmoidal air cells as well at the nasal part. This is a CT scan showing proptosis of the eye. If you draw an imaginary line between the zygomatic processes, as shown here, you will see that the eye is pushed outwards. Most of the eye is out of the orbit. What's normal is that you have to see around 2/3 of the eye should be inside that line. You can notice as well that the muscles are really enlarged here, and the optic nerve is more or less straight. Usually there is an S-shaped pattern which should be there. طبعا هذه اللي انتم شايفينها هي superior rectus. تمام. This is the large superior rectus. The optic nerve is this small curve here, which is almost straight. This is another picture showing really a very enlarged medial rectus muscle. This is a lateral rectus muscle, and this is the optic nerve. تمام. The straight optic nerve. هذه اللي هنا superior rectus يا جماعة الخير، بس عشان ما تخربطوا. Now, there are, so we talked about proptosis, which is axial protrusion of the eye. Now we have dystopia, which is coronal displacement of the eye. Either it can be displaced inwards, medially, or downwards medially, or downwards laterally, or could be upwards medially or laterally. So it's a coronal displacement of the eye. For example, if you have a lacrimal gland tumor, as this lady has, the eye will be pushed downwards and medially. If you have a frontal mucocele, the eye will be pushed downwards and laterally. Now we'll be talking about Graves' disease. Graves' disease is a hypersensitivity reaction. It's an autoimmune disease. The whole problem is that you have something called TSI, thyroid stimulating immunoglobulin, which attaches to the TSH receptor at the thyroid gland and at the soft tissue in the orbit. The real mechanism is really unknown, but Graves' disease can be regarded as a problem of the orbit rather than a problem of the thyroid itself. So Graves' disease can come with hyperthyroidism in 96%. It can come with euthyroidism, just an euthyroid person. Around 3% and 1% have hypothyroidism. Usually the disease burns out itself in 7 years, time, and mostly the real problems let's say, emerge in the first couple of years. We will talk now in details about Graves' disease. Graves' disease is also regarded as type 5 hypersensitivity reaction. If I just refresh your memory, a type 1 hypersensitivity reaction is the anaphylactic reaction, immunoglobulin E mediated. We have the type 2, which is immunoglobulin G hypersensitivity reaction, where you have an immunoglobulin attaching directly to the epitope. And we have type 3, which is immune receptor complex deposition, where you have the epitope and the immunoglobulin G depositing inside the tissue. And the last, which is the cell-mediated, or for example, contact dermatitis. This is cell-mediated hypersensitivity reaction. So in Graves' disease, you can think of it as type 2. However, we subclassified it into type 5 because there is stimulation of endocrine cells, which is not seen in the regular type 2. So this is just a briefing about the immunology in patients with Graves' disease. Now, Graves' disease can be divided into two important, let's say, phases. We have the soft tissue phase, the inflammatory phase, and then we have the fibrotic phase. So the inflammatory phase starts with periorbital lid swelling, conjunctival hyperemia, chemosis, and superior limbic keratoconjunctivitis. And then we have the fibrotic stage, where you have eyelid retraction, Ptosis, optic neuropathy, and restrictive myopathy. Let's take everyone in details. Now, these are the inflammatory signs that usually seen in patients with Graves' disease. Chemosis, where you have swelling of the conjunctiva, as you can see here in this lady. Hyperemia, superior limbic keratoconjunctivitis. Superior limbic keratoconjunctivitis is usually, it usually happens due to mucin deficiency. Mucin deficiency of the lipid layer. Goblet cells are dysfunctional. So the problem is that the sliding of the palpebral conjunctiva over the bulbar conjunctiva will be very defective. This will cause rubbing of the conjunctiva, and any two surfaces, if you rub them very well together, and there is no real, let's say, gliding substance there, you'll start to have hyperemia. Superior limbic keratoconjunctivitis is seen only in 10% of patients with Graves' disease. So it's associated with Graves' disease, but you can see it actually in other diseases related to dry eyes. Chemosis, as you can see here, also we have hyperemia and fluid in the conjunctiva. Other signs of Graves' disease, the proptosis, which is the axial protrusion of the eye, and eyelid retraction. So what is the most common cause of eye proptosis? Whether it's unilateral or bilateral, the answer is Graves' disease. What is the most common sign of Graves' disease? It's eyelid retraction. So the most common affected muscle in Graves' disease is the levator palpebrae superioris. Now, if the question asks you about what is the most common rectus muscle affected in Graves' disease, the answer will be inferior rectus, because it is the fleshiest muscle. And then comes the medial rectus, and then the superior, and then the least to be affected is the lateral rectus, because it is the least fleshiest and it is the most tendinous. Tamam? So the more sarcomeres you have, the more the affection of the muscle. Now, what happens is that with the recurrent inflammation and healing process, which happens due to the, in the between the phases, you'll start to have fibrous deposition in the muscle, And this is what we call the fibrotic stage of the disease. Now, Graves' disease can come with myasthenia gravis in 5% of patients. These are really these are really important, let's say, a subdivision of cases that you have to pick, because sometimes Graves' disease can come with ptosis. It's not just eyelid retraction that usually happens, which is the most common sign, as we said, but sometimes they can come with ptosis. Okay, so just keep that in mind. Now, what is the difference between eyelid lag and eyelid retraction? Eyelid lag is, the eye has to, the lid usually follows the eye. Whenever you are looking down, the eyelid will follow the eye. If you're looking up, it also has to follow the eye. If the patient looks down and the eyelid stays up, this is called an eyelid lag, which is momentarily, usually for a couple of seconds. It's very noticeable, and then the eyelid should follow. Usually this is due to let's say, overstimulation of the sympathetic innervation of Mueller's muscle. Gives this lag. However, eyelid retraction can happen if you have fibrotic, permanent shortening of the levator muscle. So permanent shortening of the levator muscle. So in this case, when you ask the patient to look down, the eyelid will stay up. Okay, it will not follow. Patients with Graves' disease, they have this myxedematous look. حتى subhanallah, their cheeks, their chin, their nose, everything is more or less swollen. And you can really notice that from previous pictures. there's glycosaminoglycan deposition in all tissues. But because the eye is really found in a compact, let's say, box, it's like a compartment. احنا في عنا the periorbital, which is which encases the inner part of the orbit, is really tight. It doesn't expand. Okay, in this case, in order to relieve the pressure, the eye is forced let's say, is forced outwards. تمام يا جماعة الخير. Now, what is the most important, let's say, piece of diagnosis? What we usually do is a CT scan. CT scan is a good investigation for orbital cavities. It also shows the muscle fairly well. However, we always, after that, ask for an MRI if we think that things are not quite clear for us. So this is a CT scan showing the coronal section. As you can see, the muscles are really large. We have a large inferior rectus, medial rectus, superior rectus, and lateral rectus. And this is the optic nerve. This is the muscle of the superior oblique here. Okay, as you can see. And these are the sinuses. So this lady or this man, if we want to do a 3-wall decompression, we will be taking this wall out and we will be taking this wall out in order to herniate some of the fat. However, because of the large muscles, we might also take part of the, let's say, lateral wall, or we can drill it in order to increase the size up to 10 millimeters, which means that there's around 30 cc's and you're adding like 10 cc's, 40 cc, total space will be somewhat fair. So we talked about eyelid retraction. This is a, let's say, because this is a 2D image, the eyelid should always cover the upper part, 1/3 of the upper part of the cornea. Tamam? However, as you can see here, this is a patient with bilateral retraction. This is a patient with unilateral retraction, and this is a patient with a lid lag, or even lid retraction. We don't know, because we talked about, the difference between lag and retraction is the time. And according to the picture, you cannot really judge. You have to see the patient. You have to see the lid going down. If the lid doesn't go down, this is also retraction. Tamam? This is a patient with bilateral retraction and proptosis. This is called von Greve sign. Stary look. Stary look. تمام؟ يعني صراحة stary and fearful look. Proptosis. So proptosis is seen in 30% of patients. It's uninfluenced by the treatment of hyperthyroidism. Well, that was really partly true, but usually most of patients with Graves' disease, they really worsen after iodine 131 treatment, okay, radioactive iodine. Once you shower up the epitopes and shower up the epitopes of the thyroid gland, things really with Graves' disease becomes very bad, and the proptosis gets worse, fibrosis gets worse. That's why we always urge, nuclear medicine people try to stabilize the patient very well and give them a, let's say, short course of steroid before treatment, because things will really get very bad after the radiothyroidectomy. Okay, so optic neuropathy. Optic neuropathy is seen only in 5% of patients. These are really elderly guys, above 70 years old. Usually the disc is fine. There is no edema. However, usually the patient will have sudden drop of vision within days. They come to me with counting fingers 1 or 2 meters, and the proptosis is very minimal. Most of those patients, they have Graves' disease for at least 10 or 15 years. And then all of a sudden they come with this very bad bout. The problem with those patients is that because of the long-standing Graves' disease, their muscles are fibrotic, they are inelastic. So once they have this bout of thyroid problem, the eye doesn't go out, because the muscles are so fibrotic, they are retracting the eye backwards. So there will be built up of pressure around the nerve, and this will cause compression of the nerve. Another thing is that those patients, they have really large muscles. Most of the proptosis caused by Graves' disease in the early ages, patients between 20 and 30, is that of the soft tissue type. Usually the fat is enlarged rather than the muscles. However, those with, in the elderly group, those patients have a muscular problem. Usually muscles are affected rather than the fat, and this is much more dangerous when it comes to vision. Usually the treatment is 3-wall decompression. There is no rule for radiotherapy nowadays. Radiotherapy was thought to be good at one point, but we usually reserve it for those cases that are still in the early stages of Graves' disease, and they don't have optic neuropathy. So if you see a relative afferent, if the vision and color vision is defective, then you have to jump and do your surgery. Now, nowadays we have a beautiful treatment which is coming up. This is a monoclonal antibody usually given intravenous, and it's called teprotumumab. This is a new monoclonal antibody developed to address thyroid eye problem. The drug blocks the inflammatory and immune pathophysiology that underlies thyroid eye disease. And we think that giving the medication early in the disease will help many patients to avoid decompression surgery. This drug just came out recently, or the FDA just approved it recently in December, just recently. So we have also restrictive myopathies. Restrictive myopathies, as we have mentioned, you have to differentiate what is the most common muscle affected in Graves' disease, levator palpebrae superioris. Most common affected rectus muscle, it's the inferior rectus. So the inferior rectus becomes very restricted, very shortened. It doesn't allow it doesn't relax, so it doesn't allow full movement of the superior rectus. It's very important also to bear in mind that the superior rectus is also affected. It's weak, and so it doesn't contract, nor it doesn't relax adequately. The first, usually those patients have problem with up gaze diplopia. They start to have up gaze diplopia, and then primary gaze diplopia, and then you have diplopia in inferior gaze. We usually don't attempt to do surgery for those patients unless they are really stable. You have to do your measurements once, repeat it after 2 or 3 months, and then you go until, for example, 6 months to 1 year. If they are stable, then you can do your surgery, and usually surgery is by a certain technique called adjustable sutures. So this concludes Graves' disease. Now we're going to talk about vascular orbital disorders. Now, vascular orbital disorders can be either of orbital venous anomalies or carotid cavernous fistulas. So let's talk about the venous anomalies. So the orbital veins, we have 2 major orbital veins that drains part of the facial veins, and then they drain into the superior and inferior orbital vein, which will end up in the cavernous sinus. So what does this implies? It means that if you have, for example, any small pustule in the face, this can be a nidus for meningitis. It can be a nidus for encephalitis. So this area is more or less dangerous, the area of the face. So you have to treat any infection, any cellulitis very quickly before it can get into the brain. So that's something that you have to bear in mind. Now, some people might have varicose dilatation, abnormal dilatation of the superior and inferior orbital veins. This is really a very uncommon problem. However, we teach you this because varices are very prone to thrombose. So they can come to the emergency department as a GP. It's good actually to know it and see it. You know, those patients, they can come with this look: sudden emergence of a painful mass at the lower lid, lower or upper lid. Tamam? And usually it happens after, for example, shouting, after a sudden increase in intra-abdominal pressure called Valsalva maneuver. Tamam? This can block the vein, and it will end up, as you can see here, with a thrombosed varix. This is a lower lid thrombosed varix. This is an upper lid thrombosed varix. Okay, so what is the cavernous sinus? The cavernous sinus is a pool of, let's say, veins in the brain that has a negative pressure. تمام؟ لأنه any vein in the cranium has a minus pressure. If you can see here, you will find at the edge of both areas of the cavernous sinus, you will find the third, the fourth, the fifth, and V1, V2, fifth cranial nerve, and you have inside the cavernous, you have the pituitary gland. Now, it's important that if you have rupture of the artery, which has a positive pressure and fairly high positive pressure, it can reach up to 50 millimeter mercury, into a minus pressure, this will cause compression of the nerves that are found on the wall of the cavernous sinus. So patients with carotid cavernous fistula, especially those of high shunt fistula, they will have total ophthalmoplegia. Total ophthalmoplegia. So let's talk more. So this is really shows that the veins of the face will drain through the superior and the inferior orbital vein and then into the cavernous sinus. Okay, great. Let's talk about direct carotid cavernous fistulas. Direct carotid cavernous fistula, which means this high pressure artery, which is the internal carotid artery, will rupture into the cavernous sinus. Usually doesn't happen unless you have very bad trauma. You're talking about bad car accidents, bad head injuries. Those patients are ventilated, usually delayed. You don't see them until really delayed more or less presentation, and they can't come with this look. As you can see, the conjunctiva is chemotic, the area is, and it's a frozen globe. Usually those patients, it's very hard actually to assess their extraocular motility because sometimes they can be in a coma. So you can't really know that, but if they are cooperative, the eye will be frozen because there is compression on the third, fourth, and sixth nerve. Okay, this is so important. طبعا the patient will have proptosis, chemosis, ophthalmoplegia, as we have said, but usually the visual acuity is untouched until late because the optic nerve is far away from the more or less cavernous sinus. تمام? But usually it will get affected because of the edema around the nerve, which will happen to cause a decrease in visual acuity. So direct carotid cavernous fistulas is really one of the few things that you will use your stethoscope in ophthalmology. So you put your stethoscope on the eye and you will see a thrill or a bruit. You will hear a thrill or a bruit. Along, this is the retinal vein. It will be really congested because, the venous system is not going normally back. Tamam. So this is the, as you can see, 4-quadrant hemorrhages with congested veins. So to continue, this is the direct carotid cavernous fistula, which we talked about, and this is the this is another type of carotid cavernous fistula where you have a meningeal branch, which is a branch of the external carotid artery, being eroded inside the sinus. Being eroded inside the sinus. So a slight, slow increase in let's say, cavernous sinus pressure, that doesn't cause all the bad signs, let's say, that we talked about. So those patients are asymptomatic. They can come with a tortuous vein, as we will see, inshallah, in some pictures, and they can come with an increase in intraocular pressure. So these are actually the corkscrew-like blood vessels. You can see how they are very tortuous. The eyes more or less can be white. Most of the time it's white. And you have 1 or 2 corkscrew-like blood vessels, and then you take the intraocular pressure. It's so high, usually above in the 30s or more, and it's very and it doesn't really respond to every medication because the problem is in the production. So most of those patients should be treated with dorzolamide, any treatment that will lower down the production of aqueous rather than filtration. Okay, orbital infections. Orbital infections, we have 2 important types of orbital infection. The first is the orbital cellulitis and periorbital cellulitis. We will talk about them. We have adiabatic orbital inflammation, bacteroadenitis, and orbital myositis. Okay, so let's talk about the orbital septum. The orbital septum is anatomical septum. It's not physiologic. It doesn't really have any other function other than pulling, let's say, pushing the contents of the orbit back, and it has this direct continuation with the periorbita. This is the orbital septum, which is attached to the lower part of the, let's say, the tarsus, along with, and it has this continuation with the periorbita. تمام. طبعا the orbital septum, usually if it's lax, it can allow the fat to go out of the eye, and this will cause a baggy eye, most of the elderly. But it's more or less an anatomical barrier that we rely on in order to differentiate whether the inflammation is before that septum or inside the orbit, which is behind the septum. So patients with orbital cellulitis and preseptal cellulitis. Orbital cellulitis, this is an infection of the contents of the orbit. Usually it can be secondary to sinusitis, or especially ethmoiditis in the first year of age, and they can come with malaise, fever, and the orbital signs that we will be talking about. So in patients with preseptal and orbital cellulitis, they can come with edema, redness, hotness. Ptosis is uncommon unless the patient has orbital cellulitis. Pain is there in both preseptal and orbital cellulitis. And optic nerve dysfunction, if advanced, doesn't happen unless the patient has orbital cellulitis, and the patient will have as well total ophthalmoplegia. So to differentiate between orbital cellulitis and preseptal cellulitis, both of them have edema, redness, hotness, pain. Orbital cellulitis has optic nerve dysfunction, visual acuity, color vision problems, along with ophthalmoplegia. The patient is unable to move his eye, while the eye is more or less movement is preserved in patients with preseptal cellulitis. Treatment of, okay, let's talk about the potential complications of orbital cellulitis, and then we will run to the management. Potential complications of orbital cellulitis. We have a beautiful paper written by myself and Dr. Fawaz. We talked about complications, or let's say potential complications of neonatal orbital abscess. And we really let's say assign that the orbital cellulitis usually forms an abscess, and this abscess can drain out of the skin, which is very rare, or it can easily go back into the cavernous sinus, causing cavernous sinus thrombosis, encephalitis, meningitis, or it can drain through the sinus, causing pneumonia and sepsis, okay, sometimes. So it's really important to drain the abscess as early as possible in order to prevent complications. Usually orbital cellulitis has a very good prognosis, and that's because we usually treat them early with antibiotics, broad spectrum antibiotics, imipenem, vancomycin, in order, and usually we hospitalize them for 3 days. Once you find that there is a collection, you rush them into surgery. That's why the prognosis is good, because the intervention is early. However, if you leave the patient untreated, this can have really grave, let's say, outcome, a grave outcome. So management, always hospitalize those patients, systemic antibiotics, monitor optic nerve function, and whenever you see a change, let's say in the a focal collection, you have to rush into surgery. Now, what is the most common cause what is the most common organism in patients with preseptal and orbital cellulitis? This is staph and strep. In children, in the old days, it used to be Haemophilus influenza, but after the vaccination, things really dropped down, and still strep and staph are the most common in neonatal, in let's say in infancy, and in children. In adults, usually the cause is either gram-positive or anaerobic bacteria, and it's usually due to trauma. Very bad injury to the orbit, and usually group D stripped after tooth extraction, or in very rare cases, fungal mucormycosis in patients with DM, diabetic, in patients with diabetes and poor immunity. Okay, now as for idiopathic orbital inflammatory disorder, this is a non-neoplastic, non-infectious orbital lesion. In the old days, they used to name it Kimura disease. Kimura disease, first described in 1992, I guess. They come with, as you can see, swelling. 20 to 50-year-old with a focal swelling, usually at the lacrimal gland area, but it can affect any other part of the orbit. The treatment is steroid. You give them oral steroids and sometimes intralesional steroid. It will help a lot the this disease. Dacroadenitis. Dacroadenitis is a inflammation of the lacrimal gland. It can be part of idiopathic orbital inflammatory disease. However, sometimes dacroadenitis is caused by a viral illness. Just an upper respiratory tract infection, and after that you get this lady with a huge, let's say, lacrimal gland, as you can see in this picture here. This is really a huge lacrimal gland. The lacrimal gland is really big. Usually it's self-limiting, no need for treatment. However, we give them intralesional injection of steroid or oral steroids that will really relieve the edema, and usually it will resolve within 12 weeks. Myositis is also a subtype of idiopathic orbital inflammatory disease. This really involves the one extraocular muscle. As you can see here in this CT scan, only one muscle is affected, and even the tendon is affected. Usually, what we used to learn in the old days is that usually Graves' disease doesn't affect the tendon. So you have an enlargement of the muscle without involvement of the tendon. However, patients with myositis, they have tendinous involvement, scleral involvement, as well as the inflammation of the whole muscle and enlargement of the muscle. It's very important in myositis never to give topical steroids. Oral steroids is fine, but topical is never given because it can cause scleromalacia, and it can cause perforation of the globe. Okay, so that's a very bad thing. So we usually give them NSAIDs, non-steroidal anti-inflammatory drugs. They really work fine. Mobic, Zilsep, and ibuprofen, anything that is handy, it will work really fine. طيب, Bismillah ar-Rahman ar-Rahim. Now we're gonna talk about orbital tumors. Orbital tumors can be of vascular origin. The lacrimal gland takes a very big share of those. Neural origin, and we have some miscellaneous tumors that we will be talking about. The first vascular tumor, which is a very common tumor, is called the capillary hemangioma. This is a tumor of childhood. Usually, they usually disappear within the first 4 years of life, but sometimes we really need to treat those, even though they are benign. They will regress and with time, but it's very important to treat them because they can cause amblyopia in children, and that's why we treat them with either oral steroids or intralesional steroids sometimes can be given, and rarely they can be given beta blockers if they are so resilient and resistant. Anti-VEGF also, intralesional anti-VEGF has been tried out with variable success. Capillary hemangiomas can be can come with some systemic problems like Kazabach-Merit syndrome, for example. This can cause anemia. Maffusi syndrome, also they can come with skin hemangiomas and enchondromas. And as we have told you, steroid is the mainstay of treatment, either systemic or local. Cavernous hemangiomas are these are benign lesions. They are usually unnoticeable until late. Usually they present in the third decade, fourth decade. Usually a lady comes to you complaining of ptosis in the other eye because she thinks that the eye which has the scleral show is the normal eye for her. Now they come with proptosis of one eye. Usually cavernous hemangiomas are bag of these are really pockets of vessels that are separated from the circulation of the body. 70% of those are females, and usually we treat them with cryotherapy. Cryotherapy that will, you excise them with cryo because you need to freeze the blood inside the cavernous sinus. If you mistakenly open up the cavernous sinus, the cavernous hemangioma, this can really cause a lot of bleeding. So you need to be very ready in surgery. You need either packed RBCs or full blood ready, just in case if you have excessive bleeding, then you have to substitute that blood to the patient. Usually, lacrimal gland tumors are, they obey the rule of 50. So 50% of those are just reactionary, like those that we discussed, dacroadenitis, inflammation, post-viral, idiopathic orbital inflammation. So it's just inflammatory. They come and go. 50% of them are solid. Now, 50% of the 50 solid cases are benign, something called pleomorphic adenoma, which is very similar to pleomorphic adenoma of the parotid, pleomorphic adenoma of any salivary gland. Tamam? Usually pleomorphic adenomas are benign lesions. They are packed in a pseudocapsule. It's better never to biopsy those cases, because biopsying the lesion can convert the tumor from a let's say benign lesion into a malignant one. Tamam. Always we take the lacrimal gland as an in-block dissection, okay, and then you send it to pathology. Also the lacrimal gland, now 25% of those are malignant. طبعا هذا يعني this is really high. So if you have a swelling of the lacrimal gland, it's more or less serious. يعني مش عمالنا بنحكي على مثلا breast lump. Well, breast lumps 10%, maybe 5% are cancerous. No, this is 25% of lacrimal gland lumps are cancerous, malignant. تمام? If you have, it's very rare to find a lump there. But if it's there, يعني try to be in more or less invasive in your investigation. 60% of those, the most common malignant cancer is adenocystic carcinoma, which really has a very let's say poor outcome because of the late diagnosis, and it's very invasive. It's a very invasive tumor. Within 6 months, the patient can go into 4th stage adenocystic carcinoma. Tamam. So this is a case of pleomorphic adenoma in the 4th and 5th age. As you can see, pleomorphic adenomas they can cause dystopia. The eye is pushed downwards and medially, and you can see that it's growing slowly. There is absorption of bone here. If you compare it to the other side, and and all the structures are pushed downwards, and it's smooth encapsulated. Surgical technique of excision is not really important for you guys. Lacrimal gland carcinomas. Lacrimal gland carcinoma اللي هي adenocystic carcinoma. This is really it has really poor prognosis. Usually the mortality rate is high, and it's a fast-growing mass. Mortality rate can go up to 90%. So that's why early detection is very important. Excision is important. You early excise that tumor, and in order to try to save the patient. Gliomas. Optic nerve gliomas are one of the optic nerve tumors, as well as it can be considered as an orbital tumor. Glioma is, let's talk more about the supporting cells of the retina of the optic nerve. Tamam. So what are the supporting cells of the retina? These are the molar cells. Right. Supporting cells of the optic nerve head. These are the astrocytes. Supporting cells of the optic nerve beyond the optic nerve head, oligodendrocyte. Tamam. Gliomas are tumors of the astrocyte. This is called primary astrocytoma. Primary astrocytoma. It's associated with neurofibromatosis type 1, von Recklinghausen disease. This is a autosomal dominant disorder of chromosome 17. And طبعا we all know the criteria for neurofibromatosis type 1 diagnosis. So you need skin lesions, you need CNS lesions. So when you combine those, if you have, let's say, 3 out of 7 criteria, then you have neurofibromatosis type 1. تمام? Optic nerve gliomas are treated by observation because they are really slowly growing tumors. Vision is good. Unless the glioma doesn't go back into the chiasm, or it's really disfiguring and it's causing poor vision, we do not usually excise that. And now if you want to excise it, you have to go far back. You have to take as much as you can, at least 20 millimeter, part of the optic nerve should be cut. Tamam? Radiotherapy is there is no role for radiotherapy in those cases unless you have a chiasmal lesion involvement. Meningiomas. Always gliomas should be compared to meningiomas because meningiomas are the second most common primary tumor of the optic nerve. And usually primary meningiomas of the optic nerve is very rare. Meningiomas, they come always from the cranium and then they involve the orbit secondarily. This is the most common meningioma that I've treated. Always from the cranium and then it goes down into the orbit. But if you're talking about primary optic nerve meningiomas, these are really rare. They usually come from the middle of the nerve. They are not they're not like the gliomas. The gliomas always start at the tip of the optic nerve and then they go back. تمام, in a tram track like appearance. تمام, تبدأ من وراء وبتنزل لتحت. مختلفة عن المننجيومز. طبعا meningiomas are more common in women. They are very responsive to steroid. I mean steroid deprivation or estrogen deprivation. ليه؟ Usually estrogen pregnancy يعني estrogen pills or oral contraceptives pregnancy worsens meningioma. تمام؟ Histologically, meningiomas are characterized by presence of samoma body. Samoma bodies هذولا calcification inside the tumor itself. تمام? Why am I actually giving you those pieces of information? Because these are actually the most common MCQs that you will be seeing in your USMLE, in your course during the ophthalmology course, أو يعني حتى other courses. So please just keep those in mind. This is a slow growing tumor. We usually excise it. Radiotherapy بالعادة احنا ما بنستخدمه كثير في الorbital meningiomas unless we prove they are really fast growing. Lymphomas, this is a tumor of the elderly, usually 6th decade to the 8th decade. And as you can see, this is a beef-like fleshy area. Okay, beefy red. It's beefy red. زي كأنها لحمة عجل. تمام. And أو بسموه salmon patch. ممكن هيك يعني يا تفكرها it's a salmon patch يا بتشبه السلمون أو تشبه البيف. طبعا as you can see there is a large tumor in the superior part of, usually superior, inferior, can be any part of the orbit. So this is a MRI. Oh, I didn't show you the MRI. So there is so on MRI you will find that the tumor is eating most of the orbital structures, muscles. You can't see any structures inside the MRI. تمام? Usually the radiotherapy, chemotherapy is a treatment of choice. وبدك تميز دائما احنا عندنا الاوربت هوجكن ولا لنا هوجكن ليمفوما. دائما نون هوجكن. تمام؟ نون هوجكن لانه احنا ما عندنا اصلا lymphocyte, let's say lymph nodes inside the orbit. So it's a non-Hodgkin lymphoma. تمام. Rhabdomyosarcoma is the most common primary malignancy. تمام. Primary malignancy in children. The average age is around 7 years. It's very mistaken for orbital cellulitis. ليه؟ لأنه it's a fast growing tumor. Within 2 weeks الولد هيك منظره بتفكرها أنت orbital cellulitis. You start bombarding him with antibiotics. Nothing is improving. You do a CT scan, MRI, and you start to see a mass. تمام. Usually the mass can be يعني at any part of the orbit, usually around the muscle. Rhabdomyosarcomas have have 3 types. We have the alveolar type, we have the embryonal type, the most common. We have the alveolar type, and we have the mixed type. So alveolar type is more in adults. It has a really very bad prognosis. Mixed type also has very bad prognosis. And there is a subtype of the embryonal is called botryoid. تمام. ما فيش داعي صراحة للأسامي، يمكن هدول أكثر للتخصص، بس اعرفوا لي إنه the most common is the embryonal type 70%, and the prognosis is more or less good after adequate excision and radiotherapy. تمام. طبعا why excision? Excision should be really you really need to take a lot of that tumor so that you force the cells to go into the G0 phase, from G0 phase to G1. In the G1 phase, the cells are really amenable to radiotherapy. Okay, they are very amenable to radiotherapy, and it works really fine. طيب هلا بالنسبة لل what is the most common malignant tumors of the orbit? The most common malignant tumor of the orbit in adults. This is metastatic, either from the breast, the bronchus, the prostate, melanomas, gastrointestinal tract, and kidneys. Usually they can come with enophthalmos, proptosis. So there are various presentations of those tumors. تمام. هذولا مش كتير عليكم يا جماعة الخير. Thank you so much for your time.